Good afternoon. I'm Commander Ibad Khan. I'm representing the Clinician Outreach and Communication Activity COCA with the Emergency Risk Communication Branch at the Centers for Disease Control and Prevention. I would like to welcome you to today's COCA call. COVID-19 updates, what clinicians need to know about multisystem inflammatory syndrome in children. All participants joining us today are in listen-only mode. Free continuing education is offered for this webinar. Instructions on how to earn continuing education will be provided at the end of the call. In compliance with continuing education requirements, CDC, our planners, our presenters, and their spouses, partners wish to disclose they have no financial interests or other relationships with the manufacturers of commercial products, suppliers of commercial services, or commercial supporters. Planners have reviewed content to ensure there is no bias. The presentation will not include any discussion of the unlabeled use of a product or a product under investigational use. CDC did not accept commercial support for this continuing education activity. At the conclusion of today's session, participants will be able to accomplish the following: describe sources of MIS-C surveillance data, identify resources on MIS-C symptoms and what parents and caregivers need to know before and after a diagnosis of MIS-C, list key points for healthcare providers to use when talking with families and caregivers about MIS-C, and discuss information related to COVID-19 vaccination and MIS-C. After today's presentations, there will be a Q&A session. You may submit questions at any time during today's presentation. To ask a question using Zoom, click the Q&A button at the bottom of your screen, then type your question in the Q&A box. Please note we receive many more questions that we can answer during our webinars. If you're a patient, please refer your questions to your healthcare provider. If you're a member of the media, please contact CDC Media Relations at 404-639-3286 or send an email to media@cdc.gov. We have introduced self-knowledge checks throughout the presentation. We hope you enjoy these opportunities to assess your understanding of today's session. Please do not type your answers into the Q&A box, as this may disrupt the Q&A portion at the end of the session. It is now my pleasure to welcome our presenters for today's COCA call. We are pleased to have with us Dr. Angela Campbell, Dr. Shana Gottfried-Cato, and Dr. Anna Yusuf, who are all medical officers working the Multisystem Inflammatory Syndrome MIS unit as part of CDC's COVID-19 response. It is my pleasure now to turn it over to Dr. Campbell. Dr. Campbell, please proceed.
Good afternoon. Thank you for the introduction. Next slide. Great. So I'm going to start by giving an overview of what we've learned from some of our different surveillance platforms at CDC. Next slide. Okay, so most of you probably know the intro to this, but just to make sure everyone has the same background, MIS-C is a severe syndrome characterized by an exaggerated hyperinflammatory response affecting multiple body systems. It was first recognized in April of 2020 in the UK, occurring in children with current or recent infection with SARS-CoV-2. By May of 2020, cases were reported in New York City and New York State, and on May 14th, CDC issued a health advisory recommending that healthcare professionals report patients meeting the MIS-C case definition to local, state, or territorial health departments in order to enhance knowledge of the risk factors, pathogenesis, clinical course, and treatment of this syndrome. Next slide. So to review, this is the MIS-C case definition. This is the definition that was established at that time and is still in use. It was designed to be quite broad and inclusive. The criteria include an individual aged less than 21 years presenting with fever, laboratory evidence of inflammation, and evidence of clinically severe illness requiring hospitalization, with multisystem, that's 2 or more, organ involvement, including cardiac, renal, respiratory, hematologic, GI, derm, or neuro. And there needs to be no alternative plausible diagnosis, and the person is positive for current or recent SARS-CoV-2 infection by RT-PCR, serology, or antigen testing, or has had exposure to a suspected or confirmed COVID-19 case within the 4 weeks prior to the onset of symptoms. The bottom part of that slide shows that we do accept subjective fever and the inflammatory marker criteria are quite broad and include any of those labs. One important caveat not on this slide is that some individuals may fulfill full or partial criteria for Kawasaki disease, but should be reported if they meet the case definition for MIS-C. And I also just wanted to comment on the age criteria because we have been asked about this. Multisystem inflammatory syndrome has been described in adults, so I did want to mention that. Although MIS-A appears to be much less common than MIS-C, and we won't be discussing the features in adults today. I will say, since becoming familiar with this case definition, I have actually learned that the American Academy of Pediatrics has published statements affirming the upper age limit for pediatrics at age 21. So it's reasonable to have this broad age spectrum for the case definition, particularly since children's hospitals generally provide care for those up to age 21. But I did just want to mention that MIS in adults does occur, although it is rare. Next slide. So this original call for cases back in May of 2020 set the stage for our national surveillance for MIS-C. This is a passive surveillance system in which healthcare professionals voluntarily report cases of MIS-C to their state, local, and territorial health departments, and then the health departments report voluntarily to CDC. Thus, we are extremely grateful for all of the clinicians who take the time to report and for our amazing partners in the health departments. MIS-C is not a nationally notifiable condition, but this system does provide standardized surveillance using a case report form available on the CDC MIS-C Healthcare Professionals website. We have now had cases reported from 54 US jurisdictions, including all 50 states, New York City, Puerto Rico, Guam, and Washington, DC. The cases reported to CDC are posted each month on the COVID Data Tracker MIS-C page. Next slide. So as of January 31st, 2022, we have had 6,851 cases reported, with date of MIS-C onset going back to February 19th, 2020. There have been 59 reported deaths. Children aged 5 to 11 are the age group most frequently affected by MIS-C, as shown in this histogram of the proportion of total reported MIS-C cases by age group. 46% of all reported MIS-C case patients have occurred among those aged 5 to 11, and the median age is 9 years and has really held steady at age 8 to 9 years across the pandemic. 60% of case patients have been male. A disproportionate 59% of children with MIS-C are either Hispanic, Latino, or non-Hispanic Black. Next slide. This map shows the number of reported cases in each jurisdiction by shade of blue-green color. Although I have reminded you that MIS-C was first described in the United States in the Northeast, we have subsequently seen cases in the South and West predominate. Next slide. So this graph shows the 7-day moving average number of COVID-19 cases and MIS-C cases with date of onset between February 19th, 2020 and January 31st, 2022. You will note that these are plotted on vastly different scales, with the left y-axis marking the number of daily 7-day average MIS-C cases in units of 5 with a scale of 0 to 30, and the right y-axis marking the number of daily 7-day average COVID-19 cases in units of 100,000 with a scale from 0 to 800,000, thanks to this recent Omicron wave. So despite this difference in scale, you can see that there have been 4 waves of MIS-C since the beginning of the pandemic. That's the blue curve. And that MIS-C activity peaks about a month after COVID-19 activity peaks, which is the dotted line. And this is consistent with what we know from patient data. Although MIS-C often occurs with no known preceding illness, we do have reports in which people can recall a preceding SARS-CoV-2 illness. And from those people, MIS-C generally occurs 2 to 6 weeks after their SARS-CoV-2 infection. I will note that the most recent spike in COVID-19 activity on the right is associated with the Omicron variant circulation. This grayed out area on the right side represents the most recent 6 weeks of MIS-C data, for which reporting of our cases is still the most incomplete. The actual number of MIS-C cases during this period and even going back into the previous wave of activity is likely larger. That previous wave reflects MIS-C associated with circulating Delta variant viruses, and we expect these numbers to continue to increase as additional case reports are incorporated. We are continuing to receive a lot of reports from this time period. Although we expect some reporting lag and have across the pandemic, it has been particularly difficult for clinicians and hospitals and health departments to keep up with MIS-C reporting in these recent exhausting weeks and months of the pandemic. Next slide. So here's a summary of what MIS-C national surveillance provides for us. We can do a number of things with these data, including examining demographic and clinical characteristics among reported cases, examining changes in reported demographic and clinical characteristics over time, describing treatments received, and using these data toward estimation of MIS-C incidence. On the other hand, these data are not intended to provide details of the clinical course, to assess effectiveness of various interventions or treatments, to infer causality with regard to treatment and illness resolution, or to truly quantify the burden of MIS-C in the United States. At least not using these data alone, that's difficult to do because this is a passive system. Next slide. So this MMWR was published August 14th, 2020. It was actually led by Dr. Gottfried Cato, who will speak next. This shows a nice example of one of the first overview papers to come from national surveillance, in which a latent class analysis was performed to identify similarities and grouped the first 570 MIS-C cases reported from March through July into 3 distinct classes. Patients in class 1 had a typical MIS-C picture, in which 98% tested positive for SARS-CoV-2 by serology. All patients had cardiovascular and nearly all had gastrointestinal manifestations, often with a number of additional organ systems involved and markedly elevated laboratory values of inflammation and markers of cardiac damage. These patients had significantly higher frequencies of shock and myocarditis relative to the other 2 classes, with a very high percentage, 84%, of ICU admissions. Patients in class 2 had more of an acute COVID-19 MIS-C combination picture. Only 16% were serology positive and 100% tested positive by RT-PCR. These patients were more likely to have had severe respiratory involvement with pneumonia and ARDS, and 62% had ICU admission. And then patients in class 3 were generally younger. The median age was 6 years, and that's compared with 9 and 10 years in class 1 and 2, respectively. This class had milder illness and relatively higher frequency of rash and mucocutaneous lesions, most similar to Kawasaki disease, with 44% admitted to the ICU. Next slide. So this slide displays multiple manuscript headers showing the contribution of MIS-C national surveillance data to our knowledge about this syndrome. We have learned which factors are linked to severe outcomes in MIS-C. Being non-Hispanic Black was shown to be a risk factor, and it's held up in multiple studies. In this paper, in the bottom right corner, we described the first 35 deaths, and we found that although Hispanic Latino and non-Hispanic Black persons, along with American Indian, Alaska Natives, and Native Hawaiian Pacific Islanders, these populations comprise approximately 1/3 of the overall US population of people aged 0 to 20 years. However, these groups comprise more than 2/3 of MIS-C cases, and they comprise more than 80% of these MIS-C deaths. Next slide. Here is our most recent publication of cases in national surveillance. In this, we described 4,470 cases of MIS-C reported with symptom onset from February 19th, 2020 through July 31st, 2021. We found that the frequency of severe cardiovascular complications, including cardiac dysfunction, myocarditis, and shock, including vasopressor receipt, declined over time over those first 3 waves that I showed you of the MIS-C in peaks during the pandemic. We also found that clinical outcomes, including length of hospitalization, receipt of mechanical ventilation, ECMO, and death, improved across those first 3 pandemic waves of MIS-C. Next slide. So now I'm moving on to a different